Good evening, everyone. Thank you for joining us tonight. My name is Jane Ransom, and I'm the Executive Director of the American Brain Foundation. Our foundation is committed to sharing valuable resources and increasing public awareness of brain disease. So webinars, events like this one tonight are opportunities to connect you with experts in various topics of interest around brain disease. The American Brain Foundation funds research across the entire spectrum of brain diseases because we know that brain diseases are interconnected. Curing one brain disease means we will be able to cure many. So let's move on to our topic of conversation for tonight, which is controversies in dementia research. Incurable brain diseases like Alzheimer's and other dementias gradually steal the essence of what makes someone human, often leaving their loved ones very helpless. And Dr. Petersen joins us to discuss the state of dementia research today and what the future may hold for people living with Alzheimer's and other dementias. And I'm happy to say, I think there's more and more hope exactly because of research. I'm delighted to welcome our guest, Dr. Ron Petersen. He's the director of the Mayo Alzheimer's Disease Research Center and the Mayo Clinic's study of aging. He's authored over 960 peer-reviewed articles on memory disorders, aging, and Alzheimer's disease. Dr. Petersen is the recipient of numerous awards, including the MetLife Award for Medical Research in Alzheimer's disease, the Potamkin Prize, the Kakaturian Award, and the Henry Wisniewski Lifetime Achievement Award. These awards get harder and harder to pronounce as you go down the list. In 2011, Dr. Petersen was appointed by the Secretary of Health and Human Services to serve as the chair of the Advisory Committee on Research, Care, and Services for the National Alzheimer's Disease Plan. And in 2014, he was appointed to the World Dementia Council by the United Kingdom government. Last but certainly not least, Dr. Petersen serves on the board of directors of the American Brain Foundation and on the American Brain Foundation's Research Advisory Council. Before I just turn the mic over to Dr. Petersen, I want to invite you all to put questions into the chat as the discussion goes on tonight. And when Dr. Petersen is done speaking, we'll entertain as many of your questions as possible. So welcome, Dr. Petersen, very much. Thank you for coming, and the floor is yours.
All right, thanks very much, Jane. I'm now the biggest challenge for the evening, of course, is for me to load my slides and get them projected. So we will try that, but I appreciate the kind words and certainly have enjoyed working with the American Brain Foundation for the last several years. Are the slides up, Liam, Jane? Are they showing?
Yes.
Okay, very good. So it's controversies in dementia research, but that's a euphemism. We're really talking about what's going on in Alzheimer's disease. There's been so much talk about it. Are we really making some progress? So I will talk about other dementias as well, but I'm going to focus primarily on where we are in Alzheimer's disease. So I'd like to say a few words to get us going here. I think somebody may need to mute there. I hear a little background noise.
Yeah, could everybody please mute your background?
There we are.
Okay.
Thank you so much.
That sounds better.
All right, here are my disclosures. On the left-hand column here, I do work with some of the drug companies, primarily about the design of clinical trials in Alzheimer's disease. But I want to highlight one of the grants on the right that focuses on most of our research in Alzheimer's disease, particularly at the Mayo Clinic. This U24 grant is called the Alzheimer's Clinical Trials Consortium, funded by the National Institute on Aging, but it is a public-private partnership. So we work with companies, and consequently, since I'm one of the co-principal investigators of that grant, I'm precluded from taking any meaningful compensation from the companies on the left. So while I do work with them, I make about $1.50. So there's really nothing of consequence. But nevertheless, that's for you to judge. So I'm going to chat for about 15, 20, maybe 25 minutes on a few topics. And here I'm going to be quite brief with regard to these issues: terminology, blood tests, particularly for Alzheimer's disease, and then the world of therapies. I know terminology is really exciting, so I want you to be on the edge of your seat for this. But as it turns out, terminology is a problem in the field. And I don't mean to be condescending about this, because we have difficulties talking among clinicians, among researchers on this particular issue. When I started in the field decades ago, someone would come in with a memory complaint and we'd classify them as either cognitively normal or possibly having dementia. And we got a little bit better with regard to making the dementia diagnosis earlier and earlier. But over time, we came to appreciate that this is a broader continuum and emphasizing continuum. There are no hard demarcations between these various conditions. But we had individuals who are aging normally and having some memory difficulties, some multitasking difficulties felt to be within the context of normal aging. And then we had dementia on the bottom right there, where most of us define as impairments in thinking, memory, other cognitive functions that impair our daily function. So that's dementia. But then there's this thing in between we call mild cognitive impairment, MCI. This means usually means I'm not remembering as well as I used to, but probably not as well as I ought to for my age, meaning that this memory issue is significant. But otherwise, everything else is relatively well preserved. So I'm still driving, I'm paying my bills, I'm doing the taxes, all those kinds of things. To the casual observer, I look pretty normal. But me, my family, those around me, we know that maybe my memory is not quite what it used to be. And that's important, because when I come back at the end and talk about therapies, you'll see that that is a clinical diagnosis that really is common in these clinical trials. So nomenclature, again, really, really exciting. When we broke down nomenclature and started to get into drill down and say, why is there so much confusion about this, inconsistency in the use of the terms, we came to realize that people were mixing up the clinical syndrome and the underlying pathophysiology. Clinical syndrome, we mean, what are the clinical features of this person? How much memory impairment, how much language problem, other clinical features of what's going on. Pathophysiology refers to what's the cause of that underlying syndrome. So here again, going back to the previous slide, mild cognitive impairment, dementia. Those are syndromic diagnoses. The next question we ask is, what is causing that? So I won't go into detail here, but there's an exercise underway by several of us that trying to boil this down into clarifying what constitutes a diagnosis. There's the clinical presentation, the left two columns there. The left-hand column says, what are the cognitive features of this syndrome? Memory, language, visuospatial, executive function, etc. What are the behavioral characteristics, motor characteristics, other neurologic symptoms that may portray this? And then the middle column says we take each of those clinical features and we stratify them on the degree of impairment, none, minimal, mild, moderate, severe. That then leads to the bottom line where we call it a clinical syndrome, characterizing the clinical features. Then we ask the question, okay, what's causing that clinical syndrome? We get to the far right column as the possible entities that may be impacting that clinical picture. Amyloid and tau, characteristic of Alzheimer's disease, alpha-synuclein, Lewy body dementia, TDP-43, late syndrome, vascular disease, et cetera, et cetera. So we're trying to make people appreciate when they use the term Alzheimer's disease, what do they mean? Are they referring to the clinical picture? Are they referring to the underlying biology of the disease? Or are they referring to a combination of the clinical features and the underlying biology? We're not trying to prescribe what people should do. We just want people to clarify how they're using these terms. So let's turn now to a hot area in the field, especially with regard to Alzheimer's disease, although other dementias are also dealing with these issues. Blood tests. So when we talk about Alzheimer's disease now, over the last few years, there's been remarkable progress in our ability to develop biomarkers for the underlying pathophysiology. Pathophysiology for Alzheimer's disease, the amyloid protein, the tau protein. So blood tests have been developed and have been refined quite exquisitely to really characterize a person's amyloid level based on their blood test. Tau level, so-so. It's working in that direction. So these blood tests now have been used in 3 different realms: predicting who is amyloid tau positive, making the diagnosis of Alzheimer's disease biologically by blood tests, and perhaps following therapy. Let me put up a figure here. This is something we published a year or so ago, looking at the use of drugs for Alzheimer's disease. The blue line on the top, person comes in with a cognitive complaint, you do a history exam, you make the diagnosis the person has mild cognitive impairment or mild dementia, you do an MRI scan for safety purposes, then you determine whether the person has amyloid in his or her brain using PET or spinal tap for CSF. You do ApoE testing, a genetic feature of Alzheimer's disease, because that may impact the risk profile of using the drug, and you treat the person. Well, how might blood tests intervene in this process? So in the gold line on the bottom, we see that we may be using plasma blood tests to actually determine who might be amyloid positive. That is, amyloid PET scans are great, but they're expensive and not available everywhere. CSF is great, but it requires a spinal tap. So might we be able to stratify people as to who is likely to be positive on an amyloid test, as to who might be intermediate, who might be low? Blood tests can do that. So that's one use of a blood test, predicting who's going to develop amyloid positivity on a PET scan or CSF. Let me jump over to the right then. If we decide that this person is appropriate for using one of these disease-modifying therapies, how about if we monitor the effectiveness of the drug in the blood? So we draw a plasma measure at the outset, we treat them for a period of time, we draw a blood test at a later point in time to see if, in fact, the drug is affecting the blood levels of the particular protein, say amyloid, that we're looking for in the blood. The middle use of blood tests that I mentioned was for a diagnosis. That is, it might be down the road, not today, not tomorrow, but not too far down the road, that we may be able to draw a blood test to see whether the person has amyloid and tau in the brain. These need further refinement, but I think that's the direction in which the field is moving, but we're not there yet. So bottom line, blood tests are very, very exciting. There's been a great deal of research and it's continuing. And I think we're going to get even more answers about the utility of blood tests. An important application of blood tests, of course, would be to underrepresented populations. One of the legitimate criticisms of clinical research in Alzheimer's disease and dementia, and in clinical trials research, is that they have largely involved higher educated, higher socioeconomic, often white individuals. Well, what about people from underrepresented groups? Blood tests now will give us access to the biologic characteristics, the diagnostic features of individuals from underrepresented groups. So that's an important pathway that is being explored. Okay, let's turn a little bit to therapies. I've indicated that this is something that's on the horizon and certainly something that's of great interest to people with Alzheimer's disease. So there are 2 classes of drugs for Alzheimer's disease: symptomatic drugs, disease-modifying. The symptomatic drugs have been around for literally decades now. So could be donepezil, rivastigmine, galantamine, 3 drugs that work on the cholinergic system in the brain, one of the neurotransmitters that's affected in Alzheimer's disease. There's another drug called memantine that also affects another neurochemical system in the brain. These are good. We use them all the time. They're helpful at perhaps alleviating some of the symptoms of Alzheimer's disease for a period of time, but they're not getting at the disease process. So what's been exciting in the last few years has been the development of disease-modifying therapies. So by disease-modifying therapies thus far, we're focusing primarily on one of the two defining characteristics of Alzheimer's disease, amyloid and tau, focusing on the amyloid protein itself. There have been 3 drugs now in the last couple of years that have demonstrated rather positive results in clinical trials, phase 3 clinical trials, at lowering amyloid levels in the brain. Aducanumab from Biogen, lecanemab from Eisai, and donanemab from Eli Lilly. And all 3 of these have gone through extensive investigations recently. So the short story on aducanumab, which was very controversial, received accelerated approval from the FDA in June of 2021, based on 1 positive trial, 1 negative trial, and 1 suggestive trial. I won't go into the details of the controversy here. I'd be happy to in the questions at the end. But the bottom line was that the Biogen, the pharmaceutical company, launched 2 large international trials, meant to be in parallel, and they were stopped prematurely because of what's called a futility analysis, meaning statistician looked at the data sort of halfway through and said, what's the likelihood these 2 trials are going to be positive, and came to the conclusion it was quite low, so they recommended stopping the trials. However, during the time when they looked at their data and the actual plug was pulled on the studies, about 3 months later, more data were acquired, and the drug company came to a different conclusion than the futility committee, and saying, no, I think one of these studies at least is trending positively. FDA looked at the data and said, show me more, I want to look at it, and came to the conclusion that they would give accelerated approval to this drug, meaning that they thought the drug did what it was supposed to do biologically, that is, remove amyloid from the brain, but they were less convinced that this had a clinical impact on the outcome of the patients. And so they said to the company, we'll give you accelerated approval, but go out and do another trial demonstrating clinical efficacy, and then we'll decide whether it receives traditional approval. Since then, however, 2 other drugs have come to the fore. Lecanemab, drug by Eisai, a pharmaceutical company out of Japan, did a trial called Clarity AD. And in this study, they demonstrated that, in fact, the lecanemab drug did slow progression of the disease by about 27% at 18 months. And here on the primary outcome measure here, downward progression means worsening, that the bottom black line is the placebo group, and the green line on top is the treated group. And there was a separation of performance of these 2 groups of participants at 18 months, suggesting that the drug was effective at slowing the progression. When you looked at the biological impact of the disease, the drug on the disease, you saw that it actually, the lower curve showed remarkable lowering of the amyloid level in the brain. So it did what it was supposed to do, and in fact, it appeared to have a clinical impact. So top line results from the Clarity AD trial for lecanemab, almost 1,800 people were in the study. The clinical diagnoses for entry into the study were mild cognitive impairment, as we discussed earlier, and mild dementia due to Alzheimer's disease, meaning the people had these clinical diagnoses and they had evidence of amyloid positivity by either PET or CSF. 18-month study, 27% slowing. The CDR change was about minus 0.45, what's called sum of the boxes on this measure. I'll get to that a little bit later, relative to placebo. All of the secondary measures, PET, other clinical measures, were all positive in this study. That's the good news. Bad news, there are side effects of these drugs. these drugs that lower amyloid level in the brain have the risk of producing some swelling in the brain, edema, or possibly bleeding in the brain, hemorrhage. So ARIA means amyloid-related imaging abnormalities. So these are seen on MRI. MRI is very sensitive at picking up edema and picking up hemorrhage. So there was a 12.5% rate of ARIA-E, edema, versus the placebo rate of 1.7 in this trial, and the hemorrhage 17% versus 8.7. Now, about 3/4 of these, again, these are imaging abnormalities, and about 3/4 of the people who have these imaging abnormalities are asymptomatic. That is, there's no symptoms produced by this, but 1/4 of them did have various symptoms: headache, dizziness, confusion, things of that nature. So the drugs are effective, but they may not be completely benign. More recently, we've heard from Eli Lilly and its drug, donanemab, reported the results of their Trailblazer ALZ-2 study. And this study, we haven't seen the final data in publication yet, but the top-line results seem to indicate that it was, again, an effective agent. 1,736 participants, again, mild cognitive impairment, mild dementia due to Alzheimer's disease, 18-month studies. Interestingly, this study was designed to look at tau PET levels as well. Again, the drugs are active on amyloid, but what about downstream effects of amyloid modulation that could be picked up by tau PET? And they looked at tau PET and categorized the people into low and intermediate levels of tau or high levels of tau. The primary outcome showed 35% slowing on this particular clinical instrument that they used. And again, the secondary measures with different clinical measures supported that. And importantly, 72% of the participants in the study had their amyloid levels reduced to negative by 18 months. But the drug also had side effects, ARIA-E, ARIA-H, and the percentages are reported there, 24% of the E and 31% with the hemorrhage level. So the results are somewhat comparable between lecanemab and donanemab. The drugs are effective at doing what they're supposed to do. They slow the progression of the disease by 27, 35, 40% in that range. And there are some side effects with them, which generally can be monitored with MRI. Now, you might say, yeah, you're showing me the cream of the crop here. You're showing me the best results. What about all those other studies that have been done on amyloid? We've been studying amyloid for decades, and there were many, many trials that were negative. So this plot, and I give credit to Dr. Yaning Wang, who was at the FDA for 18 years and had been looking over these trials for many, many years, put together this particular characterization, where on the vertical axis on the left there, downward means improvement in clinical performance. On the horizontal axis on the bottom, movement to the left means removement of amyloid from the brain. So with this characterization, here's a summary of many of the older trials. Note that they sort of coalesce around the 0-0 interaction. 0 clinical movement, 0 amyloid reduction in the brain. And these were all negative. So the trials that didn't move the metric of amyloid in the brain, measured by PET scan on amyloid plaques, seemed to be negative. A variety of different pharmaceutical interventions were used. More recently, however, when you look at the aducanumab, the lecanemab, the donanemab data, now we're getting a different picture. We're now getting a trend. Let me get rid of these negative studies. Now we're getting a trend that the more amyloid you remove from the brain, the more likely you are to see clinical stabilization or a lessening of the rate of progression. And here, in fact, is the lecanemab study that has been published that falls right in there. So based on these data now, it appears that we're hitting the right target, the amyloid plaques, and we are having an impact on clinical progression of the disease. But a criticism has been, yeah, but these measures that you're using are really broad, crude measures, and I'm not sure that a movement of a half a point on one of these scales is meaningful. So this is a depiction of how this looks in terms of the actual impact of these drugs. The blue dotted line indicates what would happen to an individual if the person were untreated. The red dotted line shows what would happen if we intervene with one of these disease-modifying therapies over time. The yellow box means this is the 18-month interval of a particular intervention. Only 18 months. These disease processes have been building up for years, maybe decades, and we're intervening over 18 months. What if, though, we continue to follow the people who have been treated? One would hope that, in fact, the curves will diverge even farther and the clinical impact of these drugs will grow. This is hypothetical. I must emphasize that, because it's not immediately obvious that intervening on amyloid will have a continued effect over the course of the disease. But if it did, this is what it would look like. The other question we asked then is, well, I don't get 27% slowing. I don't get 35% slowing. What does that mean? So if you translate the impact of these drugs into preservation of function, you get a little better impression of what's going on. So complex slide here, but basically it says if you look at the 18-month point, if we're able to slow the disease progression by this half a point on the scale, it means that we are, in fact, preserving function for about 4.5 months. If we go out to a 24-month trial, we're preserving function for about 6 months. And what that means is that we'll be keeping people at their current level of function with intervention for a longer period of time, 4, 5, 6, 8, 9 months as we go over time. And I submit to you to ask patients with this disease, is that meaningful? If you can keep me where I am now for another 6 months, if you can keep me where I am at now for another 9 or 12 months, is that important? I think most people would say yes. So again, these drugs are not home runs. They don't stop the disease. They don't make people better. But if we can preserve function in individuals for a period of time at that point in their life, I suggest that that might be, in fact, clinically meaningful. All righty. Let me wrap up then by saying this is a complex picture. Alzheimer's disease is not the end-all, be-all of cognitive impairment in aging. There's a whole host of things going on. So if we look at this clinical spectrum, cognitively normal, mild cognitive impairment, dementia, we say, what is impacting this? Well, we've talked a lot this evening about amyloid, A beta. That's an important process. The tau molecule downstream is another one. A beta leads to misprocessing of tau. So that's another factor. But they're not alone. Often we have something called alpha-synuclein, which can form Lewy bodies in the brain. And so in the strict condition of primarily misfunction in the brain with alpha-synuclein, we get the condition called dementia with Lewy bodies. There's another protein called TDP-43 that can produce something called hippocampal sclerosis, which can look like Alzheimer's disease with its memory impairment, impact of function in the medial temporal lobe, and this can produce a syndrome called late, which also looks like early Alzheimer's disease. Many people have little vascular problems. Of course, some people have strokes, but other people have microvascular disease, subcortical disease in the brain that can impact clinical functioning as well. Another aspect is CSF dynamics, condition known as normal pressure hydrocephalus, has various gradations that can also impact function. And I'm sure there are other entities that we've not considered yet. But what it's Alzheimer's disease, those two at the top can be very important, can be the only processes operating in an individual. But more often than not, it's just part of the picture. So the field is moving in the direction of these multiple entities impacting clinical function, and we're trying to biomarkers of each and every one of them. Hopefully, in the future, we'll be able to get measures. It would be great if we could do it in the plasma, in the blood, to see whether a particular protein is impacting an individual's clinical function more or less. Why would we want to do that? Because ultimately, we hope to develop therapies for each of these particular entities, such that the most common approach to treating cognitive dysfunction and aging is going to be combination therapy. We may have an amyloid drug, we may have a tau drug, we may have an alpha-synuclein drug, depending on this particular individual's profile of biomarkers as they're being developed. So I'm optimistic that we're on the right road. Are these drugs for amyloid the end-all be-all? Not at all. They're a first step, an important step perhaps, but a first step in the road to treat people with cognitive impairment. So let me stop there and just highlight what Jane was saying earlier, that the American Brain Foundation has been absolutely instrumental in the development of a lot of the work that I've outlined tonight. The development of biomarkers. There's a current project out developing better biomarkers for the Lewy body component that will likely contribute to where we are down the road. So I have to thank Jane and the rest of the American Brain Foundation, the American Academy of Neurology, for really spiriting the research that will help us all in the future. So let me stop there, and I will stop sharing, and I'd be happy to entertain any questions. And I may not have the answers for all of them, but I'll try to fake a few of them, and then I'll probably send you to other people who are really much more knowledgeable than I. So thanks for this opportunity, Jane.
Thank you so much, Ron. I'm going to just start off with the question, then I'm going to go through the questions in the chat. But I wonder if you could just talk for a moment about these new drugs as preventives. I mean, say you're someone who's your parent. I'll give me as an example. My parents have both had dementia. My husband's parents have both had dementia. Why shouldn't we start taking something like this now to prevent it from starting in the first place? Is that a possibility?
Yeah, absolutely. I mean, it's a great question, because as you'll notice, when I was discussing these drugs and the clinical population on which they've been tested, they're all in symptomatic disease. People already have mild cognitive impairment. They already have mild dementia. Now we're trying to treat them. The real strategy would be, let's move back up that continuum. Remember that first slide I showed, cognitively normal, mild cognitive impairment, dementia. Why don't we go back upstream? And now that we have these biomarkers, imaging biomarkers, spinal fluid biomarkers, maybe blood biomarkers, shouldn't we be moving back upstream and treat people who are cognitively normal but have the biologic features of Alzheimer's disease? And there is a trial underway right now, so-called the AHEAD trial, that's using the drug lecanemab in people who are clinically normal but do have various levels of amyloid in the brain. This is what we're doing in heart disease. We don't wait for people to have the heart attack, the chest pain, the heart failure. When their cholesterol is up, we treat the cholesterol to try to prevent or at least delay the onset of the clinical symptoms. And that's where we're going in Alzheimer's disease. So it's an excellent question, asking a very appropriate approach to treating these disorders.
Okay, I have someone here asking a question. Their brother is in Taiwan and has had Parkinson's disease for 20 years. And they're asking, is it possible to treat Parkinson's and Alzheimer's and dementia patients by phototherapy to stimulate their stem cells to replacing these dead cells and degenerating cells in their brains? My elder brother carries PD over 20 years and is not able to use chopsticks all the time. But I saw that if he wears a photo helmet and has photo pens in both ears adjusted to a certain frequency, he's able to use chopsticks in a meal. These photo light equipment are being developed by owners of computer companies for their PD supporting group at General Veteran Hospital in Taipei, Taiwan.
Interesting question. I mean, I think it cuts across several different avenues. One being that these proteinopathies, that is Alzheimer's disease, Parkinson's disease, dementia with Lewy bodies, result in disruptions of cortical networks, the communication systems in the brain. Different ones for different diseases. The proteins affect different networks across the board. But the question is, I think what the person is referring to is, can we intervene on those cortical networks? Can we do something? Can we alter the brain networks by stimulation, either auditory stimulation, visual stimulation? And there are studies underway, some out of MIT, that are looking at this strategy. So it's very, very hopeful that we can affect these diseases, these underlying processes with different modalities. Maybe a drug to get at the underlying proteinopathies, maybe some kind of stimulation procedure that would alter these networks. So I think all of these need to be open, and certainly the field is wide open with regard to considering all these different therapies. So I can't vouch for that particular one, but the strategy is being addressed more widely.
Thank you. Here's somebody saying, asking how to manage family members' dismissiveness of lingering effects of brain injury, rather than attribute the ongoing deficits to intentionality. Such a horrible situation. I assume this question could be applied to various forms of dementia too, where family members don't believe or dismiss the symptoms.
Yeah, I mean, there still is a stigma about these diseases out there. That is cognitive impairment, and you're embarrassed to talk about your degree of cognitive impairment, or is this just aging and your personality is now exaggerating some of these features? So I think these are all common responses to people who have various cognitive difficulties. And I think there's an education aspect that clearly the American Academy of Neurology, the American Brain Foundation is trying to promote as to these are diseases of the brain. And if somebody, there was a comment you made, Jane, about a person had a brain injury. So if somebody had traumatic brain injury earlier in life and now is experiencing cognitive impairment, is it due to that? Is it due to something else? Is it aging on top of traumatic brain injury? All of these are possibilities, but I think we need to be mindful that these are very common. They happen in older age. As we age, we become less resilient to injuries in the brain and other systemic factors in our bodies as well. So I think a main aspect of this is just education with regard to what is normal aging and where do we draw the line and how we can help people who are experiencing some of these symptoms, regardless of what the symptoms may be due to.
Okay. Here's someone that asks, are amyloid plaque and tau tangles still believed to be underlying causes of Alzheimer's, or may it be a symptom of the disease, especially as there are drug trials that reduce amyloid plaque but doesn't significantly improve cognition?
Well, this is what I was trying to get at with that pinwheel diagram at the end. I mean, amyloid and tau are sort of the defining features of Alzheimer's disease. But Alzheimer's disease isn't the final answer to all impairments in cognition in aging. But they may be important factors. And sometimes I think amyloid has received a lot more attention because the light has shined more brightly on it over the years, meaning we've been aware of it, we've been able to measure it in the spinal fluid, in the imaging tests, and now maybe in the blood. So it's received a lot of attention because it may be modifiable and we can measure those modifications. And I think that's what we're seeing, and that's what's happening. So is Alzheimer's disease amyloid and tau only? No, there are other factors that are impacting it. There are downstream effects, inflammation, and the like. Is it a cause or an effect? Well, that's a tomato-tomato kind of argument that you can get into, and I'm not sure there's a clear answer there. But I think the fact that we now have identified ways to measure the amyloid protein, measure the tau protein, We now have ways to intervene in those proteins, even if they're midway downstream. What if they're not the causal factors? I kind of think they probably are pretty central upstream. But even if they're only mediating factors, we can now measure them, we can intervene with them, and maybe alter the downstream function, the clinical impact of these. So I guess I think that the studies that have now demonstrated an impact on the underlying protein, its course, and now there's correlating clinical stabilization, if you will, or slowing of the rate of progression. I think that's pretty important and is encourages us to continue this line of investigation, but not exclude other entities that may impact the disease progression as well.
All right. These questions are coming fast and furious. Do you need to take a breath?
No, that's okay. That's all right.
Here's one. Why has it been difficult to develop reliable blood tests to detect hyperphosphorylated tau?
I'm not a clinical chemist, so this is one I should defer to my clinical laboratory colleagues. It's very difficult to measure these proteins and measure misprocessed aspects of them, like the hyperphosphorylation. But I must say that the clinical chemists out there have been doing a wonderful job at looking at like p-tau 181, p-tau 217. These are hyperphosphorylated forms of the tau protein. The tau protein is the primary constituent in the neurofibrillary tangle that is intracellular inside the nerve cell, destroys the nerve cell. The fact that we can now measure these hyperphosphorylated forms, and there are a variety of others. There's p-tau 205, p-tau 231, p-tau 243. There's a so-called microtubule binding region of tau that is measurable in the CSF, may be measurable in the blood. So the fact that we can get at these now and measure these proteins is enormously helpful to us in terms of characterizing the disease progression. I must say, thus far, it appears that the p-tau 181, the p-tau 217 measures may be more reflective of amyloid levels than tau measures, but the MTBR measures of the tau protein on the other end of the molecule may be more reflective of the tau impact on the neurofibrillary tangle. So we're getting more and more sophisticated with regard to measuring this particular subspecies of tau and what they mean. And they may be differentially sensitive to the length of progression of the disease. So some people are suggesting that p-tau 231 is very, very early in the disease process. 217 might be better at, now people are becoming symptomatic, how can we follow the progression of the disease? And 217 may be very, very effective at that. So again, it's a rapidly evolving field with superb scientists looking at aspects of it. But I think the p-tau work is particularly exciting.
Okay. Here's a question that relates to something you were talking about earlier, but maybe you can go into a little more depth. It's someone asking, please put the 27 and 35% slowing into more day-to-day or real-world reality terms as to what that means for families.
It's an excellent question. And we've been trying to wrestle with this issue. How do you translate this into a meaningful clinical measure for families? And I sometimes use the analogy, I didn't present the particular features of the clinical scales that are being used, but the studies have indicated that about a 0.5 change in the CDR, clinical dementia rating, sum of the boxes, is meaningful. It's an 18-point scale, but much of the scale is more severe, measures on more severe aspects of the disease. If we really focus on, say, the 1 to 6 levels, now a half a point becomes significant. And when we use this scale, the difference between a 0.5 measure and a 1.0 measure, just a half of a sum of the box, might be clinically important. Why is that? The 0.5 measure, say in memory, means, oh, I'm a little forgetful. It's sort of called benign forgetfulness. I have a little trouble. Where are my car keys? Where are my reading glasses? Stuff like that. A 1.0 measure in the memory domain means I cannot function now as I have formerly because of my memory difficulties. This memory difficulty is affecting my daily function. That's a 1.0, only a half point difference. But I would submit that most patients, families, and clinicians would agree that that is a clinically meaningful difference. So that's what the measure of 0.5 means on that graph that I demonstrate. So how does that translate into function? Well, the difference between 0.5 and 1 could be the clinical diagnosis difference between mild cognitive impairment and mild dementia. Is that a big deal? Well, it turns out it can be a big deal. In the state of California, if you are diagnosed with dementia, even mild dementia, you are required to report yourself to the Department of Motor Vehicles, and you may lose your driver's license. Okay? At the 0.5 level, the mild cognitive impairment level, you can still drive, probably. So does that have a clinically meaningful impact? So when I go back to saying, what does that difference mean of 0.5 in terms of 4.5 months of preservation of function, 6 months of preservation of function, 9 months of preservation of function, it means I can continue driving in California for another 6 months, 9 months, or 12 months. I think that's probably important to people. So those are the loose, but I think the translation of these clinical trials, 27% slowing, 35% slowing, mean that we stay at our functional level, our current functional level, for 6, 9, or 12 months longer.
All right. Well, here's a neurologist to neurologist question from Dr. Jose Cavazos, but I think we can all understand it, whether we're researchers or not. First of all, great presentation, Ron. Are you concerned about removing amyloid resulting in greater cortical atrophy in the treated patients with our novel amyloid therapies?
It's a neurologist question. It's an appropriate one. Almost all of these studies, interestingly, that have shown effective removal of amyloid from the brain have also shown increasing atrophy, meaning shrinkage in the brain. So the brain's getting smaller. That doesn't sound good. And I get it. I understand. We've been working with my colleagues for decades on brain volume measures, and you think loss of volume is not a good thing. And I think in general, that's true. But we have to look at it. What does that mean? When you give these drugs and you get a loss of volume of the brain, sometimes regionally, sometimes globally, it may not mean that you're actually losing brain substance, gray matter in the brain. It may be a fluid shift. It may be an index of inflammation in the brain. There may be other explanations as to how these drugs are working on the brain, and a measure that measures volume is reflecting a loss of volume over time. But it may not necessarily be bad. Now, sounds like I'm backpedaling here, and I may be, but there have been several studies recently and commentaries on what that actually means. Bottom line, to be honest, we don't know what that means. We don't know why giving these drugs result in apparently increasing atrophy over time. On the other hand, you say, yeah, but look at the clinical impact appears to be positive. That seems to be more impactful, but it's a good question. And the bottom line is we don't understand it totally.
All right, now we're switching gears from the neurologist question back into the trenches of all the American consumers. Couple of questions in a row here about the cost of these drugs. What is it, or are they still in trials? How do we keep the drugs from bankrupting the medical system? Is there any way the pharmaceutical companies would be willing to accept lower profits? And I'll throw in there, what about insurance coverage?
Sure, thanks. Very, very relevant. And I think we're at a point now where this discussion is going to come to the fore again. So I should have said that the lecanemab drug, the ASI drug, that was the Clarity AD study, went before the FDA 2 weeks ago, where they had an advisory committee that advised the FDA to approve or not approve the drug, and they recommended unanimously 6-0 vote to approve the drug. So the so-called PDUFA date for this will be July 6th, meaning that the FDA will be making its decision on whether this drug receives traditional approval, essentially full approval, by July 6th. Everybody in the field thinks that with the advisory committee, with the data that I briefly showed you, the FDA will in fact approve the drug. But then the next question becomes, okay, who's going to pay for it? The drug company has estimated the cost of this drug at it being about $26,500 a year, a fair nickel for most of us, needless to say. So then the issue comes up, okay, will insurance cover this, or will CMS, the Center for Medicare and Medicaid Services, cover this? Because most of the people are in the Medicare age range, 65 and above, so they're mostly Medicare people. And the answer is probably yes. The Medicare officials have gone and testified in front of Congress and said that we will, if this drug receives full approval, traditional approval, we will cover it, but they have they're operating under what's called an NCD, National Coverage Decision, which they put in place last year, saying that if these drugs are approved by the FDA, we'd like to learn more about them. We'd like to collect more data, and we'd like people who get these drugs covered by us to be in a registry. So it's not blanket coverage at this point in time, but it's likely that they will require people enroll in a registry to have the drug covered. They will cover the drug, and so there will probably be a copay for most people, but they'll cover it. And but the issue of the registry is unclear at this point in time. There are several groups out here. The American Academy of Neurology is one that's sort of thinking about a registry type process to enable people to be followed in a standardized fashion in a registry and then have CMS cover it. That sounds reasonable, and I can't argue against the rationale for collecting more data on people who are treated with these drugs. But I am concerned about the registry requirement being applied unequally in the general population. That is, as I was mentioning earlier, one of the concerns in clinical trials in the field has been the underrepresentation of certain groups, certain marginalized group, African American, Hispanic, rural people might not have access to these drugs like other higher socioeconomic person. And might the requirement of a registry enhance or amplify that disparity, meaning that physicians who treat patients from underrepresented groups may not be quite as willing to go through all the paperwork, the red tape, if you will, to establish a registry. There are going to be certain requirements on the part of the provider to fulfill the requirements for a registry. Well, that's going to perhaps discourage them from going in that direction. Underrepresented patients may be accessing those practitioners more often than others. Anyway, it's complicated, and it will be playing out in just the next couple of weeks. As for the comment about the pharmaceutical companies, you know, I can't entertain any real knowledge about what goes into the costing of those, and should they change, should they negotiate with CMS, are they allowed to negotiate with the companies is another issue. So cost is going to be an issue. There's no doubt about it, but hopefully that we'll reach some kind of equilibrium here with the requirement from CMS and the establishment of registries and coverage for people who are Medicare eligible.
Okay. I'm going to combine two more questions. One is saying, this is all about outside the avenue of drugs. One person says, can you give any weight to people who are saying that a keto diet 12 hours fasting a day and exercise can reverse the disease. And somebody else saying, can you briefly comment on other promising avenues of research outside the recent drugs, looking at inflammation and other avenues?
Right. I apologize if I focus too much on pharmacotherapy, drug development, because that's a hot aspect of it. But there's a whole other non-pharmacologic approach to cognitive impairment, aging and cognition, development of dementia, maybe development of Alzheimer's disease. But here we have to go back to my original comments about what is dementia, what's mild cognitive impairment as a syndrome versus what's due to Alzheimer's disease, amyloid and tau, the specific proteins. And I think there's a good deal of research on lifestyle factors, exercise, intellectual activities, maybe diet, staying involved in your social networks, good sleep hygiene, reduction of stress. AARP has recommended all of these different approaches to help with cognition and aging, and I think they're beneficial. Do I think that if I go out and run marathons, I will never get Alzheimer's disease? No, I can't say that. I don't think that's likely to be the case. But could I alter, if I did, engage in some of these lifestyle modifications, could I alter the trajectory at which I'm aging, my cognition and aging? And I think the answer is yes there. Will I prevent dementia? Will I prevent Alzheimer's disease? I can't say that. Could I delay the onset? Maybe. The data are fairly convincing there. So you get into issues like ketogenic diets, may be helpful. I've not seen totally convincing data on that, but certainly there may be dietary implications for brain health, just like there are for heart health. So we often retreat to what's good for the heart's good for the brain, sort of mom and pop recommendations, but it's probably beneficial. So there's a whole host of studies being done, research studies on lifestyle modification, different exercise programs and the like that are going to shed light on this. And again, at the end of the day, while I talked about combination pharmacotherapy, it's really likely to be combination pharmaco and lifestyle therapy. Again, the analogy with heart disease, that's what we do for our heart. We may take a lipid lowering drug, but we also have to get out there and do some exercise, not smoke, and engage in other behaviors that may mitigate some of the risk of developing these. So I think that's where we are with cognition, aging, dementia, maybe Alzheimer's disease as defined by those specific proteins. But at the end of the day, we just want to have a better quality of life as we age. And that's where these lifestyle modifications may very well be beneficial.
Okay. We're getting up to the top of the hour here, which is when we have to call time. I want to thank everybody for their submitting questions, and I'm sorry we didn't get to all of them. But I'm going to ask one more, and then we'll have to cut. Do you envision using these drugs that you've been discussing tonight for 18 months and then stopping them, or continuing them forever?
Excellent question. Thank you for bringing it up. I should have mentioned earlier. The trial that is under review by the FDA now from Eli Lilly, the donanemab trial, had an interesting feature in it. In addition to measuring tau levels and stratifying people, perhaps stratifying people on tau levels for an amyloid-lowering drug, they also used the design feature of treating people for a period of time when their amyloid levels were reduced down to normal. And remember, 72% of them did so by 18 months. But when people's amyloid level is down to normal, they stop treating people. And this is where blood tests that we talked about earlier may be particularly useful. Wouldn't it be interesting if, yes, these intravenous infusions are, one, expensive, and two, inconvenient? The lecanemab drug is every 2 weeks. The donanemab drug is every 4 weeks. The aducanumab drug is every 4 weeks. Wouldn't it be nice that if we could reduce the target down to zero or down to its threshold level, stop treating, follow people with blood tests? If the blood tests start to rise, indicating that the proteins may be aggregating again, then we retreat and do some maintenance therapy and follow them again. I think that's a very attractive a proposal for using these drugs. We don't have the data to document that yet, but I think that that's a very realistic and I think encouraging one from a patient perspective, inconvenience, and from a cost perspective. So, Jane, I think that's a positive note to end on.
That's great. And I do want to say, Dr. Petersen, I think as anxious as we all are to make huge progress in Alzheimer's and dementia, what we're starting to hear, like from your presentation tonight, is real encouragement and hope. After sort of going for a long period just thinking, well, we're doomed, and so this is really exciting, and I want to thank you very much for sharing with us tonight. Before we say goodbye, I want to thank you once again, all of the audience members, for joining us tonight. We'd love to see you again. We've got a great lineup of monthly webinars scheduled, including a talk about environmental toxins in brain disease coming up next month. You can also follow us on social media and stay up to date on brain disease information and research. And you can also support innovative research to find cures for tomorrow by making a donation. No donation is too small, and all are deeply appreciated. We can't do this work without your support. Thank you so much again, Dr. Petersen, and thank you all for joining us tonight. Good night.